because 4,000 people died. But if you review the literature of how many people die every day from diabetes, cardiovascular disease, and just plain old things that we tend to accept being Black, more than 4,000 people die every day from those diseases. So I want to talk about that for a moment before we go on to our main topics. Simon, will you put up the slides, please? So everybody knows or heard of diabetes. Some people call it sugar diabetes or sugar. But if you have diabetes, you are immediately at risk for early death, usually from cardiovascular death. And if you have poor control of your blood glucose, you're even at higher risk. And that risk puts you at maybe as much as 4 times normal for your age group. We know that poorly controlled diabetes, poor control of blood pressure, puts you at very high risk. And even poor control of cholesterol adds to that risk. And we know that excessive use of non-steroidal anti-inflammatory agents, such as aspirin, such as naproxen, such as what's one that starts with an M that everybody uses?
Motrin.
Motrin. All those things can lead to kidney failure. And these risk factors increase your risk for having other types of kidney disease. So one thing that I want people to pay attention to is what happens when they go to the bathroom to do number 1 or urinate. We want to know that you want to reduce your albumin creatinine ratio by at least 30%. And I'll explain what that means in just a minute. Next slide. So if you go to urinate and there's foam in your urine, and that's easy for men to see because they stand up to urinate. Women, you may have to get up and look back. But it's very important, I hate to be so graphic, but it's very important that you look and see if there's foam in your urine. That means that there's a lot of protein in your urine. And protein in your urine means that you have cardiovascular disease and that you have renal disease, probably both simultaneously. There was a study done called Fidelity, and 45% of those patients had a history of cardiovascular disease. But also in 45% of those patients, they had chronic kidney disease with a glomerular filtration rate that was considered to be normal. So you wouldn't think that looking at that particular biomarker that they were at risk for kidney disease, but they all had albuminuria, 45% of them. So they were at risk. Let's go to the next slide. Oh, and that LDL is a target too. Low density lipoprotein, that's your bad cholesterol. Let's go to the next slide. So a lot of people say, well, I don't want to be on blood pressure medicine. I want to take herbs. I'm going to tell you, if you have diabetes, please don't take herbs to control it. They will not do it. The other thing I would say that you want to make sure you control your blood pressure adequately. There's no such thing as being able to control your blood pressure with one medication. What all the literature says, it takes between 2 and 4 medications at once to control adequate blood pressure. And that blood pressure needs to be at 120/80 or lower. not 130 over 80, not 145 over 80, but 120 over 80 or less. What are some of the things that are important to control that blood pressure? Control your hemoglobin A1C, which is a measure of your glucose level for the past 90 days, and put you at less risk for kidney disease and maybe even reduce it. One medication are the calcium channel blockers. My favorite medication is called amlodipine. There's also nifedipine and others. They're called calcium channel blockers. The next group is even more important, called the renin-angiotensin system inhibitors. And those are ACE inhibitors and renin-angiotensin receptor blocking agents. Drugs that end in pril, P-R-I-L, those are ACE inhibitors, and drugs that end in things like sartans, losartan, cosartan, they're on the blocker drugs. Then there's a class of drugs called the metaglutides. And a lot of women are using those to lose 7 to 10 pounds of weight. But they also get your hemoglobin A1C less than 7. A newer class that they're making a lot of noise about now is called SGLP2 drugs. And one out now is called Farxiga. And these help reduce your loss of kidney function by between 30 and 40%, your risk of cardiovascular death by 30 to 40%. And the newest class now are called MRA agonists. These are like semi like the drug spironolactone, except they have no steroid nucleus. And all of these drugs can be used together. So this is a recommended cocktail of 5 types of drugs that if you have diabetes and hypertension and cardiovascular disease, you can use to lower your risk. And I say that as a warning. We'll present a more complete informational program in the coming weeks on this. But it is very important. Look to see if when you pee, you make foam in your urine. That means you're at significant risk. And you need to speak to your primary care doctor, like Dr. Jordan always says, about what medication will reduce that protein in your urine, what medication will reduce your risk of cardiac or renal death. Thank you very much. Let's go to the next slides. So now back to more normal stuff. The Senate took a vote. I guess they're always voting about something, but they voted to end the national emergency, a declaration on COVID-19 pandemic. And even President Biden said originally that the pandemic is over. But last week, we know that cases around the country and around the world went up for the first time in months. Why don't we speak on that a minute, our panel of moderators, Dr. Neighbors Stevens and Dr. Ivan Walks, who's chair of our vaccine committee, and Dr. Hines, our young doctor in Maryland. What do you think about what the Senate did?
Well, Dr. Maxey, I will jump in and say what do I think about what the Senate did? I think that the Senate is a political entity, and so we should expect folks to respond to things that are politically motivated, and we should expect folks to be looking to their constituents, the people that vote, for direction on how they should vote when they get into the Senate and the House and wherever else that they get. So I don't think we can look to them specifically for medical advice. So I'm not usually surprised when a political entity, whether it's the U.S. Senate or a state legislative organization or a governor, or they tell us how we have to behave because they set policy. But I don't think that we look to them I don't think we look to them to be properly interpreting the science all the time and give us good medical advice.
That's a real good answer. I think that's true. But they are our leaders, right?
I think my audio went out. Can you say no, no, okay, Dr. Maxey, people have different functions. And I think that we have to be responsible enough to get our advice from a combination of places when it comes to everyday behavior and what we personally decide to do. Folks are always talking about get the government out of my house. I don't want the government telling me what to do in my city or in my state. And then we use what the government does to make decisions. I think that we absolutely need to not break the laws. And I think that there are opportunities we have as individuals to decide how we're going to best protect ourselves, especially when it comes to our health. So yeah, the Senate does this and the House does that and the president does that. And then I take all of that. And like you said a few minutes ago, I talk to my primary care doctor about what I need to do personally.
I like that. I like Dr. Neighbor Stevens.
You're on mute, Barbara.
That's probably a good thing because I had been muttering under my breath. I think that they could have spent their time much better voting on gun control than trying to mess around with COVID.
That's true. So that's the most exclusive club of mostly men in the United States, and some of them like limited control, no federal control until it has to do with something that they want. So how does our representative from the state of Maryland see this, Dr. Hines?
Well, what I would say is that specifically in the health space, the ending of the public health emergency is going to have some implications for what is covered and paid for, especially in the telehealth space. So, as you're going to go see your doctors and things like that, especially as we move to 2023, make sure that you talk to your insurance, because there's state implications of that, like whether the states are still, your individual state still has a public health emergency, but there are definitely some potential implications because a lot of rules were relaxed during COVID as far as telehealth is concerned. So that's one of the things that you should certainly make sure that you talk to your insurance providers and your healthcare providers on as far as what their telehealth services will be, and will they still be the same? What providers you may or may not be able to see. For example, during the public health emergency, people were able to practice across state lines, and some of that's going to end as the public health emergency is over.
I think those are very good points. It's very important that people do call their insurance companies and find out exactly what the insurance companies will pay for and what they won't. And I'm figuring that a lot of these big companies laying off thousands and thousands of employees is because they probably picked up extra staff thinking this pandemic staying home was going to be longer than it was. So there being thousands of people laying off. And I guess that's going to affect their insurance as well. So those are very good points. Let's go to the next slide, Simon. So the SARS-CoV-2 subvariants are now officially dominating new infections. The BO 1.1 and the BO 0.1, as per NBC News. And unlike several monoclonal antibodies, the one, especially the one that we use called Paxlovid, appear to be effective against all of these variants, including the Omicron BA 4.6. And this is in the New England Journal of Medicine. So what this says to me is that the variants are subject to these things that we're using, the monoclonal antibodies, the 5-day treatment of Paxlovid, et cetera. Dr. Ivan, you were in charge of our committee on that. Why don't we clear up any questions about what people should be doing? Right now, it looks like we should still be using our previous edicts to take these post-COVID and use our same vaccines. It seems like we're still in the ballpark.
Well, Dr. Maxey, we don't have newer things, right? So we're not coming out and saying, okay, well, let's stop doing this and let's start doing that. What we have is we have variants that have begun to dominate, as you said, and we have evidence that what we have available continues to help us. So I think that whenever news like this comes out, we may assume that, oh, well, all of our instruction is going to be different. And our instruction is not going to be different at this point. Our instruction is that we're supposed to be getting our vaccine, getting the new bivalent booster after we've gone through the base base vaccination. And then if we don't feel good, we should take a COVID test and see what's going on. We can see if we have COVID, see if we have the flu, see if we have a cold, because a lot of things continue to go around this time of year. Folks are not wearing masks as much as folks did to a large extent. And so things are being passed around. And we know, in addition to what you have on this slide, that other things are making people sick now that weren't circulating as much over the last couple of years. So what I'm getting from what you're putting on this slide now is that let's keep doing what we've been doing, using what we've been using, doing all of the non-medication and vaccination things that we should be doing in terms of our behavior, our distancing, our mask wearing, our hand washing, all of those things.
Dr. Neighbor, as a pediatrician, what are you advising parents that have children to do? Is there anything different in what you see?
No, there's nothing different. There are going to be many more children sick than have been over the last 2 years, and parents need to keep a close eye on them. If they start showing signs of problems with breathing, that is a big red flag and is an indication to seek attention. They just have a runny nose, just keep an eye on them. But if they start having difficulty breathing, fevers that you can't control, and they're not acting the way you've ever seen them act before with an illness, you need to reach out to your pediatrician.
What do you say, Dr. Hines?
I think that these two slides in sequence are really important, right? Because one is the part where we said the COVID pandemic is over. But that is not the same thing, as we can see in this slide, as COVID is gone, right? COVID's not gone. It's still around. It's still something that for all, as Dr. Watts and Dr. Neighbor Stevens already spoke to, you still need to be vigilant over. And in fact, what we also learned in these last couple of years is not only will all of these things keep the COVID potentially, away, they will also keep other germs and things like that away. As we go into Thanksgiving and the holiday season, it's unfortunate when you get sick before you have a planned event, right? But rather than spread it to all of your loved ones, you might have to change plans. You might have to pivot. You might have to cancel.
Dr. Neighbor, thank you, Dr. Hines. Dr. Neighbor said something that struck at me. I have a brand new 1-year-old who doesn't yet talk. I guess he talks his own language. But he got for his birthday, he got a box full of balls, like they have a ball thing when you go to McDonald's, you can jump in and hide in the ball. Well, he dived in his balls. So I dived in, and he looked at me, and looking at his face, he thought something had happened to me. So he was sad for a minute. I didn't know young kids could grieve. But when does that really happen, Dr. Neighbor? How do we know that a young child who may not be yet verbal is grieving? Is that possible?
Well, I don't know about grieving. I think that that's a interesting concept. I think that would not have been my interpretation of what your grandson did. My interpretation of what your grandson did was he didn't understand what in the world you were doing jumping in his box of balls. To the point I had to know, parents know their children. I never, if I had to examine a child and I couldn't, and the parent had brought the child in because they said something was wrong with the child, and I examined the child and I couldn't find anything wrong with the child, I never said to the parent, nothing's wrong with your child. Because if they have observed something different, their observation is totally valid. I just wasn't able to find what was the cause of their concern. And we would have a conversation about next steps. Children have very basic activities. They eat, they go to the bathroom, and they sleep. So when children start demonstrating differences in their normal behaviors, they are fussier, they are not eating the way they normally eat, there's a change in their bowel habits, there's a decrease in their urination pattern. These are all the child's way of letting you know something is not right here. You need to check things out. And then the more alarming signs of difficulty breathing, which I suppose I should elaborate on. Difficulty breathing in young children is used to describe when the skin in between the ribs sucks in with each breath. That's called difficulty breathing, in addition to, stuffy nose, cough, and wheezing that you can hear without the aid of a stethoscope. These are all signs that something is going on in that respiratory tree. So good observation will let you know when something is not right with your child.
Well, thank you so much. Simon, let's go to the next slide. So Dr. Neighbor Stevens and Dr. Walks, we all participated in the conference on long-term long COVID. Wonder if one of you would just go to the next couple of slides on long COVID. Dr. Neighbor?
Sure, Dr. Maxley, I can read through the next couple of slides.
Okay.
Long-term sequelae of COVID-19 are recognized as a major public health issue. Bullet number 1, life stressors contribute substantially to worse functional, cognitive, and neuropsychiatric outcomes 12 months after COVID-19 hospitalization. Bullet number 2, over 50% of subjects reported significant life stressors at 12 months post-COVID-19. Bullet number 3, other predictors of poor outcome include older age, female sex, baseline disability, and severity of index COVID-19.
So
We
we
can
can
go to the next one and then just discuss them together.
Yes.
Okay. All right. The next bullet, in adults hospitalized with COVID-19, we found that traditional predictors of poor outcome, including older age, poor pre-COVID functional status, and index severity of illness, were independently associated with worse MRS Bartholomew index and persistent COVID-19 symptoms. Next bullet, we additionally found that life stressors significantly impacted disability, depression, fatigue, sleep, and post-COVID-19 symptom metrics. The next bullet, interventions targeted at ameliorating modifiable life stressors merit further investigation. Neurological science. And did you want to stop there, Dr. Maxey, or go on to the
Let's see
next
what
one?
let's see this last one.
Okay. Patients with long COVID who also reported significant activity limitations by race. So this is a survey of 50,258 US adults. The shares of Americans with long COVID who report significant activity limitations by race. The data is from a survey of those adults. Non-Hispanic Black Americans, as well as Hispanic or Latino Americans, are more than 10 percentage points above the national average of 25%, while non-Hispanic White Americans are 5 percentage points below it. And those percents are non-Hispanic Black, 38%, Hispanic or Latino, 37%, US overall, 25%, and non-Hispanic White, 20%.
So this seems to me to be making some social statements that make long COVID a very significant issue for communities of color. And we also know, I don't think there are any diagnostic measures or biomarkers to prove that you have long COVID or not. Am I right or wrong?
At this point, it's symptomatic, but I wanted to put all of this in another context, because the public, not our very well educated viewership, but the population in general doesn't seem to handle new information well, especially new information related to COVID. And I just wanted to put this all in the context. As you all recall, we had our symposium almost 2 years ago now, hard to believe. And at the around the same time, the NIH announced that they were going to initiate a study on long COVID, which they did, in fact, launch. And as a result of this investigation and research effort coordinated by NIH, but occurring all over the world, not a week goes by, it seems now, when a group here or a group there is reporting their findings. And I'm saying all of this to say is I still think we're at the tip of the iceberg on all of this. And I would say hold on to your seats, because as time goes on, I am fairly confident we're going to hear some things about long COVID that's going to scare us, worry us to a much greater degree than any of the information that has come out so far. But as far as the impact on the populations of color, they were more seriously impacted by the initial infection, and there were proportionately more disease burden in those communities than in the white population. So I don't find these numbers at all surprising. I mean, this is what I certainly would anticipate, if not worse, later on.
Dr. Hines, you got a comment on this?
I would agree with I would agree with Dr. Neighbor Stevens. The other thing I would also say is, when you think about life stressors, what do brown people kind of have a whole lot of in general? Maybe life stressors. I think the good news of some of this is, and again, it's probably not a leap to think that life stressors and being in a more stressful environment probably had is part of the reason why there was a disproportionate impact of, COVID infection itself on those same communities. The potential good of this is the concept of SDOH, or social determinants of health, or the things that can be stressful in your life, your ability to access, education, safe housing, food, water, all of those kinds of things are finally really getting more frontline attention from things like the Center for Medicaid Services and some of your governmental health entities. And that is also trickling down to what your insurance companies and the payers are willing to invest in and help support. So that might be a positive in some of this.
Dr. Walks, I have a question for you, if you don't mind. So I know that, as Dr. Neighbor said, Blacks are often on the front lines and tend to get more of the COVID and maybe tend to have more of these stressors that persist after long COVID. And we know that we have many illnesses in our community, such as ACE, the adverse childhood events and whatnot. But does this also reflect on the other side that communities of color, at the same time they have more adverse events, may have more resilience, or is that not necessarily something that's known yet? Do we have more resilience, more ability to bounce back, or just to be downtrodden, if I'm trying to state that right?
So Dr. Maxey, we are not destined to be more downtrodden. Those of us who are people of faith do not accept that we are destined to be more downtrodden. Have we been more downtrodden with respect to policies and resources? Well, yeah, we Dr. Hines just mentioned some of the determinants that are getting more attention. Let me say this. The men's group that we have at church, one of the things that we do is we ask we ask our group to pray for folks that we know that are going through particular challenges. And every once in a while, somebody has a challenge related to a family member or a friend or someone close to them with COVID. And yesterday we talked about a young woman in her 30s that was really struggling with long COVID. And what continues to surprise me is that every time someone has a really bad outcome, we had a brother with cardiovascular disease with very challenging outcome, major surgery required, et cetera. This young woman with long COVID challenges. And you started us off, Dr. Maxey, talking about the more than 4,000 people a day that are dying from these chronic illnesses that we know are ravaging our community. And it seems like it's just information to us. I don't know that anybody who doesn't know that diabetes, blood sugar, whatever we call it, is a problem in our communities. I remember being a kid and watching one of my best friend's mom get toe came off, foot came off, below the knee came off. And these are things that are in our community. And I think from a mental health perspective, I'm always struggling with, and even when I was a state health officer, I'm always struggling with how do we get our community motivated to move on these things that are ravaging our community. And I'd be happy to just continue to get advice on that. Dr. Jordan talks to us a lot about the importance of folks having that primary care doctor resource. I'm happy to see Dr. Lawson is on today. Maybe he can help us understand why the news that we get about the challenges that impact our community differently than they impact other communities. And we continue to have this sort of lack of response to things that are killing us, even when they are hurting folks in our own families. So yeah, I don't have a better answer than that, Dr. Maxey. I feel sad when I continue to see this kind of information coming out about what's happening in our community.
But I think you answered my question in a sense that I think we are resilient people. And I think the first set of slides I showed was the fact that we all, at one time, thought there wasn't much we can do about diabetes except control your blood glucose. But now we can control blood pressure on top of it. Now we can control the level of kidney failure. And there's some slides later to talk about how we can even deal with dementia. So I think we are resilient. But the more we know, and the more we know there's hope, not only physically and medically, but also spiritually, I think we'll do better and better. That's my thought. So
Well, I'm sure I agree. And, or at least I'm not sure that I agree totally, but it may also be a slight difference in definition. I am going to consider resilience in the context. I know that there are several different components to resilience, but I'm going to address just exhaustion of one's energies and resources by a given factor as a limited definition of resilience. I don't think resilience to a large degree has anything to do with the way our community responds to almost anything medical, including medical. Our community still has a longstanding distrust of medicine. And then secondly, those things that concern the three of us, in terms of conditions adversely impacting our community, are nowhere near the top of the list of the community. The community has a whole different set of priorities and concerns, and that's not new. And I'm not sure what we can do to change that, but that's a significant part of the problem. If you don't respect medicine, and if you're more concerned about making your house note or paying your rent, or whether or not you can get your car working, if you have enough money to get it fixed, or have enough money to pay the insurance so that you can drive it, or whatever else in terms of life activities are going on that are consuming your attention, whether or not you have diabetes, whether or not you have heart disease, is not something that you really are that concerned about. And I take a step further. When you start talking about obesity in our community, we can talk all day long about the health impact of obesity, but if it's not considered something that's a problem, you're talking in the wind. So I think we have a disconnect around what is maybe scientifically true, but what is of concern of the community. Now, I may be oversimplifying this, but I really think that that is a major thing that's going on here.
Yeah, I feel that you have hit the nail on the head. I remember back when I was younger, going to church, the average size of both men and women was a lot larger than it is today. And I just thought that as you got older and you were Black, you're supposed to get fat and you're supposed to be ungainly. And I think we were rationalizing that was just a normal part of life. So I think you're very right. Dr. Hines, what do you think?
I was going to say something similar. I think that one of the things that is lacking, especially in the health space, is a sense of agency, right? The sense that I think the general population actually feels like there's something that they can do. Because on the one hand, it's like once you get some of these diagnoses, it's as if it just is, right? So we're not talking about ways to get rid of it. We're not talking about cures for these things. So it's just something that you kind of live with. It just is. And I'm not exactly sure that in general that our community, and for the reasons you just stated, unfortunately, some of these chronic diseases are so ubiquitous that they seem normal. They seem like a normal part of aging. Like that's just what's supposed to happen over time. So I think that's where some of the lack of action comes from, I think, is because, well, what am I supposed to do with that? In addition to the part where you have other fish to fry, right? Other things where you may think that there's something that you can actually do about it, beyond
in some ways, some of the disease states. And especially because here's the other thing, beyond our cohort of listeners and things like that here, a lot of people don't really understand. They don't even understand what's going on. Even those that are engaged in the healthcare system, they're doing their best to follow directions, which is not necessarily the same thing as understanding.
Excellent, excellent. Dr. Walsh, you want to chime in on this?
When Dr. Neighbor Stevens said, you know, what the three of us think, I know she was leaving Dr. Hines out because she was talking about the older people. So thank you, Dr. Neighbor Stevens. So I'm now officially one of the old people. I want to say this. Dr. Maxey, you know my mom very well. My mom is 90 years old and was diagnosed with diabetes when she was probably in her, I don't know, 40s, 50s, something like that. Been taking medication all this time. Well, last month, she went to the doctor. Let me back up. A year ago, she started staying with my sister down in Atlanta, who eats very differently than we eat up here. My mom left to go to Atlanta. She had a cane to kind of help her get around a little bit. And to skip to the end of the story, as of last month, my mother doesn't use a cane to walk around anymore or to walk up and down steps. And her doctor stopped her little tiny bit of glyburide she was still taking and said, you know what? I can't find any evidence that you have diabetes anymore. And I think a lot of it is what we prioritize and what we do. And the fact that Dr. Maxey's former patient is 90 years old and walking around without a cane and no diabetes is an indication that so much is under our control. So I go right back to what Dr. Neighbor Stevens, what Dr. Hines said about the things that get in the way of us being able to focus on getting healthier. And if somebody at 90 can get healthier, it's never too late.
So you must tell me something about your sister's dietary habits.
Oh, you go to my sister's house to eat, you're going to eat well, but you're going to eat well, if that makes sense. So, you know, you won't get anything from Popeyes. Not that I like Popeyes, but I think you have to be very careful about how we eat and how we move around. This is not hard stuff. It's not hard science. It's things that we know. Dr. Maxey, Dr. Lawson probably heard me call him out earlier, and he's got his hand up, and I know that he can help us with understanding some of this.
Please recognize Dr. Lawson.
Can we take the slides down for a minute, please, Simon?
Okay, I just want to note that the issue that you're raising is an important one. You got to remember that we have multiple sources of information now. One of the important sources is what do we have to do to survive from slavery, in which we've had to have high energy food, that was sustaining. And so we developed dietary habits that were useful for dealing with spending all your day in hard labor. There's a lot of high carbohydrates and fats, and a lot of that is still happening. In addition to that, we also have a media system in which there's a lot of emphasis on carbohydrates, high fat, and also what is important in terms of making folks, quotes, attractive. If you ever get a chance to listen to talk radio, where there are huge debates, where it's constantly referring to the need to look good, but also to eat high fat, high carbohydrate food. One of the big issues now is, I'll put it bluntly, trying to get some of the sanctions taken away from marijuana, which is known to increase eating, and which is diverting efforts. It's people talking about the importance of raising marijuana farms, but at the same time not talking about getting fruits and vegetable farms and other healthy foods. And then on top of that, a colleague of mine has now passed showed that we've learned to deal with stress and adversity with our own system. We talk about comfort foods, and these foods I eat high fat, high carbohydrates, and others are foods that are comfortable. they're sedating and make you feel relaxed. But they also, in the long run, do awful things to your health. And then on top of that, we're also facing a world in which the important thing is, how do you deal with this chronic stress? The COVID, as you mentioned, the data shows depression and stress have increased during COVID. Now, I might add, tied in with the diabetes, the complications related to diabetes increase during the time of COVID. And they are all related to people more sedentary, eating more, doing less, being stressed out. And I just want to make final important point is, you also mentioned the issue of amputations. Amputation rate in our community is high. I think DC used to be second in the country in amputations, not because of trauma, gunshots, or anything like that, but because of poorly managed diabetes. And those rates increase during COVID. So we got vicious cycles. We may be doing things that are necessary for our community and are helpful, but we're also facing multiple challenges from within our own community as well as externally, both in terms of media, in terms of our past history, and in terms of how people manage acute problems with limited resources.
Wow.
Thank you, Dr. Lawson. Let me go back and I hope somebody's putting something in the chat, but let me go back to Dr. Neighbor Stevens as a pediatrician. Is there something more that we as parents, aunties, uncles, grandparents should be doing to start our kids off knowing how to eat healthy and not necessarily just being turned on by so-called soul food? What do you tell parents?
It starts at the very beginning, and my buddies are not on, I don't think, but it starts at the very beginning. They need to be breastfed. If they're not breastfed and they're bottle fed, do not enroll them in the empty bottle club. A baby does not need to consume 8 ounces of formula every 4 hours. And so we literally force feed our children from the time they come home. And then so that they don't eat until they're satisfied, they eat until it's all gone. And then when they transition to table food, they're not the ones going to the grocery store and they're not the ones cooking the food. It is clearly on the shoulders of the parents to prepare healthy menus to their children in appropriate portions. And then finally, children are sponges. They sit there and they take in everything that they see. So if mommy and daddy are sitting there eating stuff that they shouldn't be eating and eating more than they should be eating, that is the model that is being set. So there's a lot that the family sets the tone for when it comes to eating habits and providing what is nutritious.
So, for example, I've seen mothers take baby's Gerber food, Gerber's baby food, and she'll put salt, pepper, and butter and cinnamon and stuff in it. How should a mother feed her child more healthy after he's eating so-called table food or baby food or whatever? Give us a few guidelines on that.
Well, this is how it worked in our household. We didn't use Gerber or Heinz or any of the others. When either my mother, my father, or my grandfather, because my father, all three of them cooked in our household. When the meal is prepared for the family, portions of the food that was appropriate for whatever stage of development we were, was prepared for us. So, for example, if mashed potatoes was going to be the dish, there were potatoes after they were boiled, set aside and mashed with a little milk for the younger child. as we got older, or when we were infants, and then for my children, because my grandmother stayed with me when I had my children, when we cooked stuff on the weekend, we would blend it up, put it in ice trays, put it in the freezer, pop out the cubes and put them in plastic bags, label what they were, so that when we went to fix dinner for the infants, we could melt a cube of squash, or we could, melt a cube of pureed chicken that had been prepared when the family's chicken was cooked on Sunday. So there are a lot of ways that we can go about this healthy eating without even really relying on Heinz and Gerber, if we cook at home.
Dr. Hines, would you comment?
Dr. Maxley, Dr. Clark, I'm sorry, has been patiently having her hand up for quite a while.
Okay, let's go to Dr. Clark, and I'd like Dr. Hines to comment on her kids.
Oh, sure. I'll try to make this, as brief as possible. Just wanted to tell you about a couple of things I actually do in my practice. When you talk about this resiliency, I know you're more or less looking at it from a perspective of just mentally, how we're able to cope. But I did want to let you know, I test heart rate variability in my clinic, which allows me to look at the integrity of the autonomic nervous system. And by me being able to do that, it does give me a window into physical and mental stresses. So from that standpoint, another value it does give me is resiliency, believe it or not. I have not had an opportunity to write this up scientifically, but I have noticed that people who are faith-based actually have a more balanced autonomic nervous system, which usually will allow them to have a better resiliency, which I think at some point will play into us as a people as to why we are challenged with so many different things, but yet we still rise. So, that is yet to be proven, but I do think it's true. I also wanted to mention, just in reference to when we're talking about looking at long haulers COVID, we've got to look a little deeper than just a regular CBC and a CMP. So I think we're going to have to look more at other biological markers, looking at the neurohormonal transmitter system to see what's going on with that in reference to how we're going to really be able to push through this the long COVID thing. And also doing mental health screening. So just to give a resource, Dr. Max, you're very familiar with this company, the virtual clinic, that's been very, very helpful in helping me to get this type of testing past just what's regularly out there to help me get a better integrity about what's happening with my long COVID patients, as well as doing a mental health screening for 3 minutes. So I just wanted to put that out there, because we're talking about issues, but let us also talk about resources and solution as well. Thank you.
Thank you. And I want to remind you that Dr. Lawson is one of the inventors and progenitors of that M3 testing that Dr. Clark is talking about. Dr. Hines, would you comment a minute on feeding kids?
So I'll say a couple things. As a mom, and my kids are about 20 months apart, I had lofty goals of, making all of their baby food myself. And I bought the little jars and I had the little cubes, and it got to be a lot to keep up with. But I will also say one of the things that I had to remind myself of is a baby's palate and an adult's palate are not the same. Right? It doesn't require butter and salt and sugar and all of that stuff to,
For them to eat.
For them to eat the food, right? The apple itself, right? The softened apple itself is fine as an apple, right? Or as whatever, as blended carrots or whatever. So that was something that I had to learn as a parent, right? Like, just because I don't want to eat it doesn't mean that they don't want to eat it. The other thing I would also say about modeling is, and one of the things I used to say to my patients all the time, the same healthy foods that are recommended for you are the same ones that are recommended for your kids, right? So they don't need the soda any more than you do. They don't need the salt any more than you do. Any of the stuff that you don't need for your diet, they don't need it either. So you're not doing yourself or the kids a favor, like, oh, I bought the donuts, but I'm not going to eat them. They're for the kids. They didn't need it either, right? Like, so just don't buy the stuff that nobody needs to be eating in the house. another one that I used to say is this. Because especially when you're talking about teenagers and things like that, one of the things that I think as a parent is that I do is I'm not buying that, right? So if you have your little allowance and you want to buy, within reason, something that I'm not supporting, I'm not buying your candy. That's not one of the things that I buy. I'm not saying that you live in the world, right? So you're going to have access to things. You're going to go to birthday parties and all the rest of that stuff. I get it. But that's another place to set a boundary. What are you, parent, endorsing? Right? We don't have a whole bunch of Kool-Aid and sugar drinks and all that kinds of stuff. My kids like water. My son happens to be a vegetarian. I am not. It has made me have to grow in my cooking a whole lot because, but in the end, I'm better for it. Rather than trying to make him eat what was convenient for me, I have adjusted. And in the grand scheme of things, we are all in this household going to be better for it. So I think there's a couple things, adjusting as a parent to, sometimes I wish I could have done it the Dr. Neighbor Stevens way and everything would have been fresh out of been fresh. It just wasn't. But I did have a choice in whether I bought organic stuff or whether, what combinations I bought. I still have choice as a consumer to try to get the healthiest things that I could get.
Well, thank you very much. But I do know, even as a parent, that we train our kids what to eat, and we make sure they taste salt, which they don't need to taste. We make sure they taste sugar, crispiness. Like I love fried fish. That's probably one of the worst things I could eat. So we have to watch how we train our kids' taste buds, that they don't necessarily have to be trained in a way that will make them want the wrong kind of food. Let's go to the next set of slides and let Dr. Walsh has a comment at this moment.
I do, Dr. Maxey. While Simon is pulling the slides up, first I'll make my comment, and then Dr. Jordan just raised his hand. I'd like to make sure we recognize Dr. Jordan. As we're looking at our kids and what they're exposed to and how we respond to their needs and what have you, let's not forget that kids have a lot of mental health needs as well. And as young people are growing up and being exposed to different things, we just have to be aware that kids babies and infants, we may not know whether or not they can express grief if Dr. Maxey jumps into their ball pit, but I think that there are other things that kids are exposed to that can cause them to have some mental health consequences, and it's important that we don't just dismiss that. Dr. Jordan?
Thank you. It was good hearing what was said earlier, but I think it doesn't happen overnight. I went to hear the Philander Smith College Glee Club. They had the males on the back. The plank broke. And me and another guy went over to see what happened. Well, there were 4 guys on the back. 3 of them weighed over 400 pounds each.
Oh my.
And I asked them, why do you weigh so much? And I know they took it as me being offense. So I'm not being offensive. You don't need to weigh 400 pounds. It's not helping your voice, not helping anything. And you didn't go to sleep weighing 150 pounds and wake up weighing 400. This was a gradual process, period. I mean, we still have too many kids. And if you go to the high schools in the area, there are too many, and people get mad at me when I say it, but they look more like hippos in drag than young Black men. There is no reason for a young Black male to weigh 400 pounds unless he's gonna go walking through the jungle naked and risk getting bit by a poisonous snake. And that ain't gonna happen. But most of them don't have a primary care doctor. And we still need to do something now to get what we know is a good value out from just our group into the greater Black population. And we need to focus on 1 or 2 things. I can't think of any reason why any young kid or any old kid really should be smoking. And there's no reason for any kid to weigh 400 pounds. You haven't got to be skinny, but there is a cutoff. You do not need to weigh 300, 400, 500 pounds, period. That's going to affect your health.
So
And
can you talk a minute about BMI? I know it's not totally relevant, but give people an idea of their height to weight ratio, what it might be.
Body mass index. When you weigh 400 pounds, there is no body mass index. That is atrocious. No, I think I don't want people to be skinny, but there is a reason. But I think when we see, whether it's mama, daddy, someone with a BMI over 28, we need to start wondering. But 30 is high, and our doctors need to be doing it. But you don't need a BMI of 40. And there is no reason for you to have a BMI of 35 or 40, period. Something is going wrong, and we need to be doing something about that.
Can
So
I just
Dr.
chime
Jordan,
in on that too?
Go ahead, Dr. Hines.
You know, one of the things that as you were speaking, especially after Dr. Walker's last comment about mental health and what we've been talking about in stressors is, I think one of the other things that we also have to remember is a lot of people are literally eating their pain, right?
You're right.
And some of what we are seeing reflected in you know, folks with morbid obesity, including the morbid obesity of children, is an outward expression of some of their inner pain and some of their inner trauma and things like that they have not figured out other ways.
You're right, and it isn't helping. I ran the Oasis Clinic for 42 years. In 42 years, the Black women I only had 2 who had not been raped. Of the men, 64% gave a history of being molested in childhood. That's a huge problem. And I only had one doctor whom I could send patients to who helped them, and that was Michelle Clark. I think not this one, but the other Michelle Clark. But the other therapists did not know how to deal with someone who had been raped. That's a big problem. And we need to deal with that better than we have been doing. Yes, when someone rapes your kid and he's 8, 9, 10 years old, you can look at him now as age 35 and he's still dealing with it. I had a woman come in 2 weeks ago, way overweight, and I finally asked her, were you molested when you were a child? She said, yes.
And I think
the next question I asked was, how many times have you had sex with the guy who molested you? And she just burst out crying and said, 19. 19 times, yes. I mean, molestation is a huge problem. I keep saying that. It's a big problem.
We have to put that on we had one speaker on that related to Dr. Sherrod a few weeks ago, but we might need to repeat that. Dr. Walks, you're about to say something before Dr. Hines started in?
No, we can go ahead and move, Doctor. Well, Dr. Maxey, I did want to draw attention to a couple of things that were in the chat. One of them, Dr. Cutter, I'd encourage everyone to go to the chat. Dr. Cutter has a couple of very, very useful comments, and also a resource that she put in related to our earlier conversations about amputations. And then Linda Hall put in the chat something that we tend to forget, that if we are, as physicians, going to be role models for some of the things we talk about, not all of us look like role models. Not all of us act like role models. I know Amen. Doctors who I know physicians that smoke cigarettes, a lot of cigarettes that they smoke. I know physicians who, I'm sorry?
A lot of them are pulmonary doctors.
All the worse. And then the comment in the chat is about morbid obesity and how many doctors are morbidly obese. You know, a lot of us are. And maybe it relates back to Dr. Jordan's comment and Dr. Hines' comment about what we deal with. People, there's an old kind of flippant comment, physician heal thyself. A lot of us need some help with how we are treating ourselves based on what we've experienced. And so it's not a bad thing for us to think about that.
Let her for a minute, let her make her comment, and then I want to move on.
I'm sorry, Dr. Maxey?
You can unmute Dr. Cutter for a minute, let her make her comment. They're usually rare words here, and then we can move on to the slides. You see Dr. Cutter, Simon?
Yep, she's
Yes.
unmuted. Go ahead, Dr. Cutter.
Good afternoon. I just threw some things in the chat as everyone was speaking, because I think there's so many great points being made here. I mean, it's just so valuable. And, I did have the comment about limb salvage. I think it's important to recognize, that sometimes the treatments that we get in our community are the extremes, right? And I really like it when people question their physicians, not in a disrespectful way, but, it's good to get a second opinion just to make sure that things are on the right track. So that's kind of my comment about limb salvage. I put 2 physicians' names in the chat that deal with limb issues, whether it's ischemia, diabetic limbs, things like that. The other thing I put in the chat, I was just talking a little bit about stress. And I agree with the person who said earlier, we eat our pain. There's a lot of ways to deal with stress. There's a lot of ways to deal with, disenchantment. But, people who have limited resources sometimes retreat into something they can access. And what's that global access is food, right? We can always buy fast food and we can buy snack items. And that would be a source of pleasure if you can't go to the show or the movie or the concert, whatever that you really want to go to. So we can really find that kind of pleasure in physical activities, getting out, walking, exercising. That is a great stress reliever. It's a mood elevator. Once you elevate your mood and relieve your stress, it puts you in a great position to interview for other jobs and find other sources of income and to be more creative. I mean, and that's just one of the 7 things that I usually talk about in terms of health and wellness. And finally, in terms of BMI, healthy BMI, in the standards ends at about 25, and then you're overweight 25 to 30. But I think in different communities that varies some. And so I would give it about 27 in the African-American community. And then overweight is probably about 28 to 32. And then obesity really starts in that above 30 range. Morbidly obese starts at 40. So that's just some clarification. Excellent program as usual. Thank you very much.
Hey, Dr. Cutter, let me ask you a question. Is there a simple calculation that you can do on the back of a napkin for BMI? I know it's more difficult than that. But is there a simple one that the average person can do to determine their BMI?
I think the simplest thing for people to do is do a Google search, look for a BMI calculator. Just do a Google search on BMI calculator. You can usually select whether it's in kilograms or pounds for the weight, or what the height is in centimeters versus inches. Put your height and weight in there and let it do that. There is a calculation, but simple is a matter of opinion, right?
Well, thank you so much. And lastly, tell us who you are.
Well, I'm Dr. Cutter. My specialty is surgical oncology, and I'm a subspecialist in obesity medicine. I like to focus on health and wellness, especially perioperative, as well as peri-oncologic treatment. Though I like to work with patients on weight management and what I call right sizing. Everybody doesn't have to be a size 00, but it is important to be a healthful BMI. But in addition to that, there's more to it than that. It's more than exercise. It's more than nutrition. There's hydration, organ detoxification, and it goes on from there. Stress, relationships. I have, like I said, I have 7 factors. I'll put my website in the chat just in case somebody's interested in learning a little bit more. Thank you. Have a great one.
So much, Dr. Cutter. Simon, let's go to the next slide. We got just a few more minutes, and we got a few announcements at the end. So it says of the nearly 24 million adults who currently have long COVID, more than 80% are having some trouble carrying out their daily activities, according to the CDC. And this matters that it's nearly 3 years after the pandemic, and this has left millions of newly disabled people. Medical researchers continue to search for an effective treatment, but we don't even really know what long COVID is. We have no diagnostic way to determine what it is. But in the big picture, long COVID symptoms can include shortness of breath, cognitive difficulties, and symptoms that worsen over time. And some people even have with minimal physical activity or mental effort are wiped out. Let's go to the next slide. So this basically says that there are economic questions with COVID, there are diagnostic questions with COVID, long COVID, and we probably need a lot more research. But the main thing I've been focusing on is the loss of cognitive power that happens a lot of times with that. Let's go to the next slide. Let's go to the next slide. So Dr. Walks, this is somewhat in your wheelhouse. If we just can make short work of the next 2 or 3 slides, and just, they could be a little bit helpful.
Okay,
Just-
I'll just read through it quickly, Dr. Maxey. First bullet is observational studies suggest that angiotensin receptor blockers in hypertensive adults are associated with lower postmortem indicators of Alzheimer's disease pathology. Andesartan, an angiotensin receptor blocker, has a positive cognitive effect in mild cognitive impairment with hypertension therapy of candesartan on biomarkers and clinical indicators of Alzheimer's disease in non-hypertensive individuals with biomarker confirmed prodromal Alzheimer's disease. So Dr. Maxey, if I were to say that, if I were to say that controlling your blood pressure with the right medicine can help with Alzheimer's development, is that a fair way to look at this?
That's a fair way, and in particular, the class of drugs, candesartan, is what you call an angiotensin receptor blocker. That is a type of drug that we recommend for treatment of blood pressure. Losartan, candesartan. Remember, anything that ends in sartan is a blocker. Go ahead to the next slide. And it's going to turn out that all these things are connected. There's no just one system, it doesn't affect another. So blood pressure does affect your brain and how it functions. You mind reading this one?
Next bullet, among non-hypertensive prodromal Alzheimer's disease, candesartan is safe and likely decreases brain amyloid biomarkers, enhances subcortical brain connectivity, and has favorable cognitive effects. These findings suggest that candesartan may have an important therapeutic role in Alzheimer's disease and warrant further investigation given the lack of clear treatment options for this devastating illness.
Now, if I'm correct, I think that some of the symptoms of Alzheimer's are thought to be due to poorly folded or wrongly folded tissue that's in the brain. Let's go to the next slide. And those of a certain age, we're all concerned about this Alzheimer's. You can make quick work of this one, Ivan.
Tau aggregates are present in multiple neurodegenerative diseases known as tauopathies, including Alzheimer's disease, Pick's disease, progressive supranuclear palsy, and corticobasal degeneration. Dr. Maxey, you are really taking us to school this afternoon. I just want to make that editorial comment. Such misfolded tau aggregates are therefore potential sources for tauopathy biomarker discovery. Screens revealed that site-specific p-tau antibodies can differentiate Alzheimer's disease from non-Alzheimer's disease brains. Our results demonstrated that p-tau 198 detection can not only differentiate Alzheimer's disease from non-Alzheimer's disease controls, but also diagnose Alzheimer's disease from related 4R tauopathies, PSP and CBD. Promisingly, p-tau 198 was able to discriminate mild cognitive impairment from cognitively normal brains. Their work provides a new avenue for developing diagnoses and differentiation tools for Alzheimer's disease and related topathies.
Well, that says you older people stand by. There may be a cure coming, or at least a diagnosis coming. Just a moment. We know that control of diabetes, type 3 diabetes is also known as Alzheimer's disease. Control of blood pressure with certain types of agents, such as aspartans or angiotensin receptor blocking agents, help control cognitive function. So it's better to be in good health and control the biomarkers that we can. And that's so important. And we should probably stop here. The rest is on the culture of food, and I want to talk about later. Why don't we put the slides down and just discuss Alzheimer's for a minute and some of the things that we think can make it less, even though we don't have a definite answer yet. You want to start that, Dr. Walks?
I think, Dr. Maxey, that the Alzheimer's disease is difficult for a lot of reasons. The actual diagnosis of it is sometimes unclear. There are other things that can cause dementia that we tend to ignore. Folks have recurrent little tiny strokes, as they're called, that people recover from, but over the course of time can really impair cognitive function. I'm going to yield the rest of my time to my brother, Dr. Lawson, who just put his hands up, because if anybody knows about this, it's Dr. Lawson. Can we unmute Dr. Lawson? Go ahead, sir.
Just want to note that, again, want to give note to Dr. Fuller, who's the first African-American psychiatrist and who was in the lab, probably discovered the amyloid plaques, because there's some debate about it in terms of Alzheimer's. Saying that, I also want to note that the recent studies show that 50% of variation of Alzheimer's is not due to genetics, but due to environmental factors. And as you know, hypertension, diabetes, others, all are risk factors for Alzheimer's. Also, early adverse events in childhood are predictors not only of terrible things later on in middle life, but also in disorders such as Alzheimer's and a lot of physical conditions. So we can do things now that can have an impact in terms of the quality of life and prevention of dementia, even while we wait for some new drug treatments to develop.
And thank you so much, Dr. Lawson. Are there any comments or questions in the chat? Dr. Neighbor Stephen?
A very important point was made that obesity and inadequate sleep can impact brain function. There is a question, an interesting question. How does this information relate to Lewy body dementia?
Dr. Lawson, Dr. Walks?
I'll let Dr. Lawson come back and handle that. One of the things that's in the chat while Dr. Lawson is getting unmuted is kind of what I was alluding to earlier, but Dr. Clark, of course, made it clear, all Alzheimer's is not Alzheimer's. We tend to, every time someone begins to kind of lose their speed with recall, we think they're developing Alzheimer's. Every time somebody can't remember things or mixes things up. My sister has a term for it called spaghetti junction that she talks about, how when you're young, all of the spaghetti is uncooked and you can get from one place to the other along the strand. And as you get older, sometimes the spaghetti can get, so it's hard to pull one strand from the other or see where strands go, and people can get confused. And at some point you can overcook it and it just becomes mush and you can't find one strand from the other. I find it useful. Thank you, Dr. Gibson, for saying TIA, transient ischemic attack. I tend to explain things to myself in very, very simple terms because it helps me to keep everything kind of clear. At the same time, that whole spaghetti junction construct in my head helps me understand what sometimes folks are doing when they're trying to get from one strand all the way down to a clear memory that they used to have as a clear memory, and now the memories are a little bit mixed up.
Dr.
So,
Walter,
Dr. Lawson, can you do the
Walter,
Lewy bodies for us?
Dr. Walter, we call that disease CRS, can't remember S disease.
You know what, Dr. Maxey? I'm gonna have to make a house call. I'm coming out to California for you.
Dr.
Dr.
Lawson,
Lawson?
Yeah, I just want to note again, the fact that we don't know the etiology means that we may have a number of different diseases
Right.
lumped under one thing. Whether it's Lewy body dementia is a subtype or is a total different disease, and then there are others such as that involve with a similar, very kind of psychopathology, pathophysiology, including prefrontal disorders. There's also in Parkinson's disease that develop a dementia that looks very much like Alzheimer's. So I can go on and on about these. The important thing is that the final common pathway is cognitive impairment that may or may not be supported by other forms of Lewy body dementia. Have to differentiate those folks who have a lot of psychiatric comorbidity, which is also often overlooked when we think about Alzheimer's. The problem with Alzheimer's is not so much that people forget things early, but that many of these folks at some point in the illness may develop frank psychosis and other symptoms, which end up make them unsuitable for many nursing home settings or staying at home. So these kinds of other kinds of symptoms are very important in terms of how do you manage someone with Alzheimer's and what kind of outcomes can we look towards. I've seen folks who've ended up in long-term psychiatric facilities misdiagnosed with schizophrenia and others, who actually had various subtypes of psychosis associated with Alzheimer's. And we now know that some of our own psychotropic medications increase the risk of death for folks who also have comorbid psychotic features. So Alzheimer's can be a complex disease. We right now don't have medical treatments for all of these, though the goal is to try to keep people out of nursing homes, and hopefully as we develop, find ways to keep folks being able to function in positive ways. Not everybody has to be a CEO of a company when they get elderly and start developing cognitive impairment, but there are other very, very useful ways in which folks function in our community.
well, thank you.
And just to add to that, Dr. Lawson, it was mentioned a little bit earlier that some of the things that happen to us when we're young can really be impactful. A lot of the young folks who are boxing and get hit in the head a lot, folks that are playing certain kinds of sports and get hit in the head a lot, can have an impact later in life. So we just need to be to take it all the way back to the pediatricians. We need to protect those young brains.
Well, thank you so much. We're gonna close in a minute. I want to bring up a couple of things. For anybody, I'm going to ask anybody who has high blood pressure and who has diabetes or cardiovascular disease to make a request of their primary care physician or whatever physician you go to take a urine sample at your laboratory and measure your albumin to creatinine ratio. That'll be very important. If they don't know what to do with it, I'm going to have somebody put my email, which is randall.maxey02@gmail.com in the chat. You can feel secure if you want to send it to me for an interpretation. There may be a lot that can be done for you and with you. Get your urine albumin to creatinine ratio and discuss it with your primary care physician. Or if you don't have a primary care physician that you feel comfortable with, send it to me and I'll be happy to discuss that with anybody who wants to save their kidneys, their cardiovascular life, etc. In addition, coming up in the next couple of weeks, we're going to have a program concerning good eating habits and plant-based foods. And we've got a guest coming up next week. We've got a dietitian named Miss Tillery, and also a gentleman named James Jordan, who's written a book on plant-based eating. And we're going to have both of them discuss some of these foods. And I've got a few slides on There are even projects now of growing food in laboratories, whether it be chicken meat, beef, lamb, etc. And we'll talk about some of those issues. Also, starting the first of the year, our subcommittee on programming, I want to change the time of our meeting from 12 noon Pacific to 1 o'clock Pacific. It'll mean we're going 1 hour back on the clock or up on the clock, whichever it is, so that we will start at 1 o'clock Pacific, 2 o'clock Central, and 4 o'clock, I'm sure I'm messing it up, 4 o'clock Eastern. And we're going to try to limit
it would be 2 o'clock Mountain, 3 o'clock Central, and 4 o'clock Eastern, Dr. Maxey.
Okay, good. Appreciate that. And in addition, we're going to try to have tight discussions, and we're going to have a program where we bring news items, somewhat like we did today, for your interest and your education, still on health disparities that exist and affect our communities more than others. And we're going to try to have a program that lasts an hour, certainly no more than an hour and 15 minutes as we move forward. So those are the things I wanted to speak about in terms of formal final comments. Dr. Hines, Dr. Walks, and then Dr. Stevens and myself.
I will just say that we covered a lot today, and thinking about these final comments, and with Thanksgiving coming, as we think about all the things that we're grateful for, one of the things that came to mind during all of this discussion is there are a lot of ways in which we have the ability to impact our health. And especially as we approach the end of the year, which is often a time where people think about what they want to do differently and how they can do better, that kinds of things. What are thinking really about what are some of the ways that you actually can demonstrate some agency over your own health, right? Because all of this stuff can seem very overwhelming. Like we covered a lot of different things that can seem like, I don't know what to do about all that, but by picking a place to start, right? Picking a place to, all right, well, maybe I could do 30 minutes of cardio twice a week. Maybe I could find that, or maybe I could cook more, something, right? Figure out something, because all the things that we have in common in this whole discussion was there are ways where your choices can impact those long-term outcomes, whether it was long-term COVID, whether it was, your risks for Alzheimer's. We all have some ability to do something to impact our health in a positive way, either for ourselves or for the generations that we're modeling. And happy Thanksgiving to all of you. And hope everyone can find something to be super grateful and thankful for.
Thank you, Dr. Hines.
So a couple of things. I like the fact that that Dr. Gibson put in the chat, eat less and move more. In the spirit of finding a place to start and kind of trying to stay in my lane a little bit, I really appreciated a lot of what Dr. Cutter shared with us today. And one of the things Dr. Cutter put in the chat, and I'll just pick one, is sleep. Unlike BMI, sleep is real easy to measure. What time did I go to bed? What time did I wake up? Right? We know that sleep matters a lot when it comes to mental health and overall health. And so I would just encourage folks to don't not pay attention to your sleep. So I don't, when I was in medical school, I slept 3 hours a night. Yeah, we all did. We were probably all under 40 at that time too. So there is something about protecting your health and trying to protect your sleep. And the last little comment I want to make is just, I'm thankful for Dr. Maxey. Dr. Maxey is willing to talk to anybody. Dr. Maxey is willing to put his personal email in the chat to help people. Many, many years ago, when my mom was getting ready to check out, Dr. Maxey became her favorite doctor. I'm still mad at him because I'm supposed to be her favorite doctor, but Dr. Maxey took care of my mom. And I think that the fact that Dr. Maxey is leading this effort that we do on Sundays and absolutely is a giving person is something that on this Thanksgiving week, I'm thankful for. don't take it, don't let it go to your head, Dr. Maxey. Just stop it. But I'm thankful for you, brother.
Thank you. That's Neighbor Stevens.
I think my parting remarks today, because I agree, we have covered a lot of territory, very important territory. But at the end of the day, I think it's critical that we remember that all things in moderation and balance in our lives. If we can just kind of keep it simple, it'll go a long way to taking us to the goals that we're trying to reach.
Well, thank you
Amen.
so much. As my final comments, I'd like to give special thanks to my newfound friend and Dr. Ken Steiner. And a lot of times I get sort of rambunctious and I talk about black and white. Well, my AME Zion brother is Dr. Ken Steiner, and I wish him well after he had his accident. And I don't want anybody to misconstrue that I may talk a good game, but I really love people in general, especially people that are for our communities. And I thank God for Dr. Steiner and his well health. I also want to leave in prayer Dr. Pointer, who hadn't been with us for a few weeks because he had some surgery. And in addition, he's buried under, was it 5 feet of snow in Buffalo?
Yes.
So we pray for Reverend Pointer. I'm sure he'll find a way to dig himself out. And I have thanks for my co-moderators, Dr. Neighbor Stevens, Dr. Walks, and Dr. Hines, and Dr. Jordan, Dr. Lawson, Dr. Jesse Sherrod, and all those others who help us pull this program off every week. Thanks, everybody. Have a great, great Thanksgiving holiday, Christmas holiday coming, and see you next week. Thank you, everybody.
Good night, everyone.
A time change will start January